Hello everyone. Hello everyone. I'm Anas Al-Ubaidi, and the topic for this lecture or this session is advanced review of gastrointestinal and renal disease documentation. And it is within chapter 30, which is about review of gastroenterology and nephrology scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Advanced review of gastrointestinal and renal disease documentation is a crucial component for medical scribes, aiming to excel in comprehensive and accurate medical documentation. Gastrointestinal, or GI for short, and renal diseases are among the most complex and multifaceted medical conditions. They often involve overlapping symptoms such as abdominal pain, nausea, vomiting, changes in bowel habits, edema, and/or fatigue, which can stem from a variety of underlying causes. Thorough and precise documentation is essential to correctly differentiate between these conditions, develop appropriate management strategies, and improve patient outcomes. The complexity of GI, gastrointestinal, and renal disease documentation arises from the intricate anatomy and physiology of the involved organ systems. For instance, abdominal pain could indicate conditions ranging from gastritis to appendicitis, while fatigue and swelling may suggest anything from acute kidney or renal injury to chronic liver disease or chronic hepatic disease. Additionally, GI for gastrointestinal and renal conditions frequently overlap, as renal dysfunction can lead to gastrointestinal symptoms and vice versa. For example, patients with advanced kidney or renal disease often present with nausea and vomiting due to uremia, with dehydration from severe diarrhea may precipitate acute renal failure. Capturing all relevant details such as onset, progression, and severity of symptoms is critical to understanding the interplay between these symptoms or systems. An accurate history and physical exam are the cornerstones of effective documentation in GI and renal cases or kidney cases. History elements like recent travel, dietary habits, medication use, and family history provide crucial diagnostic clues. Physical examination or physical exam findings, such as abdominal tenderness, distension, or flank pain, coupled with laboratory results like electrolyte imbalances, liver function tests, and urine analysis results, help paint a complete clinical picture. These details must be documented systematically to ensure every piece of information contributes meaningfully to diagnosis and treatment. Another unique challenge in documenting GI and renal or kidney diseases is the frequent use of diagnostic tests. Comprehensive documentation of imaging studies like abdominal ultrasounds and CT computed tomography scans, as well as endoscopic evaluations, for example, colonoscopy, cystoscopy, must include key findings described in the context of the patient's symptoms. Similarly, accurate transcription of lab or laboratory values such as creatinine, glomerular filtration rate (GFR), blood urine nitrogen (BUN), and stool studies is instrumental in assessing disease progression and response to therapy. Medical scribes must not only record these details with precision but also synthesize them in a way that facilitates logical diagnostic reasoning for the care provider. GI, gastrointestinal, and renal kidney diseases often require a multidisciplinary approach for optimal management. For example, a patient with cirrhosis may need coordinated care from a hepatologist, nephrologist, and nutritionist, while someone with inflammatory bowel disease (IBD) may benefit from input from gastroenterologists, surgeons, and dietitians to manage multi-system involvement and complications. Medical scribes play a vital role in documenting communications between these specialties, ensuring that plans remain cohesive and all aspects of care are accounted for. This level of coordination enhances the continuity of care and minimizes risks such as conflicting treatment strategies or omission of critical interventions. It is also essential to address the importance of precise documentation for compliance and legal purposes. Medical scribes must ensure that all documentation adheres to coding standards for ICD-10 and CPT billing, and includes informed consents for procedures and complies with HIPAA privacy regulations. This is particularly crucial in chronic conditions like kidney disease or renal disease, where treatments like dialysis require comprehensive documentation of eligibility, treatment plans, and patient education to support proper reimbursement or reimbursements and liability protection. Key points: mastering symptom documentation for GI and renal or kidney disorders. Effective symptom documentation is vital in the evaluation of gastrointestinal, GI, and renal or kidney diseases. Accurate and thorough records of patient symptoms enable healthcare providers to make precise diagnoses and determine appropriate or proper care strategies. Detailed history taking. Key elements here document detailed timing, duration, and triggers of symptoms like abdominal pain, nausea, vomiting, diarrhea, hematuria, or dysuria. Example: right lower quadrant, pain lasting 8 hours, worsened by movement associated with nausea and low grade fever. The importance here helps differentiate between urgent surgical conditions such as appendicitis and less severe causes like gastroenteritis. And there is a summarized diagram summarizing the breaking down effective symptom documentation. Characterization of pain focus area: record location, radiation quality, sharp, dull, burning, severity, and alleviating or aggravating factors. Example: severe epigastric burning, pain radiating to the back, worse after meals. Usefulness here: this documentation can help differentiate between conditions like peptic ulcer disease and pancreatitis. And here is a summarized diagram on diagnosing abdominal pain causes. Gastrointestinal symptoms. Details the document include the stool characteristics, color, consistency, frequency, vomiting patterns, bullous, blood streaked, and appetite changes. Example: black tarry stool for 2 days, denies bright red blood or abdominal pain. Relevance here: stool characteristics can provide clues to conditions like upper gastrointestinal GI bleeding or malabsorption syndromes. And here we have a summarized diagram summarizing the GI gastrointestinal symptom documentation. Renal or kidney symptoms. Key features here: not changes in urinary patterns, urine color, presence of blood or protein, and any associated systemic symptoms like fatigue or swelling. Example: decreased urine output for 2 days, dark colored urine, and mild swelling of the feet. Significance here: these details help identify conditions such as acute kidney or acute renal injury or glomerulonephritis. And here is a summarized diagram summarizing the understanding of renal symptoms or kidney symptoms. Systemic and non-specific symptoms. What to capture here: fatigue, fever, weight loss, or generalized swelling, which may indicate systemic involvement. Example: fatigue and anorexia over the past month, accompanied by a 10-pound unintentional weight loss. Clinical impact highlights systemic conditions like chronic renal or chronic kidney disease, CKD, or gastrointestinal malignancies. Here is a summarized diagram on analyzing systemic symptoms and medical diagnosis. Diagnostic standards for GI and renal disorders. GI and renal diseases often rely on a combination of physical examination findings or physical exam findings and lab or laboratory studies and imaging for accurate diagnosis. Meticulous documentation ensures the health team has access to a clear picture of the patient's clinical status. Lab or laboratory data. Key values to record include creatinine, blood urine nitrogen, BUN, glomerular filtration rate, GFR, liver enzymes, AST, ALT, and bilirubin. Example: creatinine 2.1 mg per dl, GFR 45 ml per minute per 1.723 meter square or m square, elevated ALT at 60 IU per L, the ALT. Impact here helps differentiate between intrinsic renal disease, liver dysfunction, or conditions causing overlap. Imaging studies here What to document, describe findings from ultrasound, CT, or MRIs, including organ size, structural anomalies, or masses. Example, ultrasound reveals 2.3 centimeter gallstones with the gallbladder within the gallbladder without evidence of duct dilation. Relevance here guides acute management decisions such as surgery or medical treatment. Endoscopic procedures essential data document findings from procedures like colonoscopy, EGD, or cystoscopy, including biopsy results if applicable. Example here colonoscopy confirmed diverticulosis in the sigmoid colon, no active bleeding observed. Purpose here provides critical data for visualizing and treating conditions such as abnormal lesions or obstructions. Kidney specific diagnostics focus areas record results of renal biopsies, urinalysis, and electrolyte panels for renal pathologies. Example, urine analysis indicates significant proteinuria and red cell casts suggesting glomerulonephritis. Utility differentiates glomerular versus tubular kidney diseases. Stool studies and markers, what to include, not results of fecal calprotectin, occult blood testing, or pathogen analysis. Example, fecal occult blood positive stool culture reveals Clostridium difficile. Clinical use helps confirm infections, inflammation, or GI bleeding sources. Handling complex GI and renal cases, integrated care, and comprehensive documentation are essential for managing conditions involving both GI, gastrointestinal, and renal systems. Overlapping symptoms, their approach documents symptoms that may indicate involvement of multiple organ systems like vomiting due to uremia or diarrhea leading to dehydration, renal, or kidney impairment. Example, persistent nausea, vomiting in a patient with advanced CKD, chronic kidney disease. Laboratory findings support metabolic acidosis. Value contextualizes symptoms and systemic conditions to guide holistic treatment. Chronic disease management focuses record longitudinal symptom patterns and responses to treatments in conditions like IBD, inflammatory bowel disease, or CKD, chronic kidney disease. Example, flare-up of Crohn's disease, as Crohn's disease or CD is a kind of IBD, inflammatory bowel disease, characterized by abdominal pain and diarrhea responding to steroid taper. Purpose here tracks disease progression and response to therapeutic interventions. Emergency care cases, critical elements to document. Timelines, interventions performed, and diagnostic clarity for cases like septic shock due to peritonitis. Example, patient presented with rebound tenderness, CT, confirmed perforated diverticulitis, emergency laparotomy performed. Clinical importance ensures accuracy in high-risk scenarios requiring immediate care. High-risk interventions, what to include? Pre-procedure assessments, informed consents and outcomes in cases like dialysis or endoscopic retrograde cholangiopancreatography, ERCP for short. Example, ERCP removed a 5 mm stone from the common bile duct, no post-procedure complications. Why it matters: reduces risk of legal liabilities and ensures complete records for follow-ups. Patients with multi-system disorders, document here, note contributions from specialists in cases like hepatorenal syndrome, HRS, or systemic inflammatory diseases. Example, care team includes hepatologists, nephrologists, and nutritionists addressing advanced cirrhosis with HRS. Objective here, establish cohesion and planning multidisciplinary treatment strategies. Supporting multidisciplinary care, GI and renal disorders often involve collaboration among various medical teams. Effective documentation ensures coordinated care. Team communication role here, document interdepartmental discussions and specific roles for interventions. Example, nutritionist initiated renal protective diet, nephrologist adjusting phosphate binders. Value here highlights continuity in care strategies. Post-procedure recovery focus here include recovery plans and therapy adjustments after surgeries or interventions. Example, following paracentesis, instructed to monitor for recurrence of ascites and scheduled diuretic titration. Purpose here tracks follow-up plans effectively. Integration of renal and GI contributions, examples advanced CKD, chronic kidney disease patients with secondary hyperparathyroidism linked to GI absorption issues. Documentation elements include correlation of renal or kidney function tests with bone and mineral abnormalities. Patient education focus. Key elements here include dietary advice, lifestyle modifications, and medical management steps for liver or renal diseases. Example, low sodium diet initiated to manage ascites, advise avoidance of nephrotoxic drugs. Benefit enhances patient adherence to therapeutic interventions. Legal and billing standards. Compliance here incorporate coding accuracy and informed consent for chronic management plans. Example, consent obtained for peritoneal dialysis, ICD code N18.6 documented for ESRD. Outcome ensures smoother reimbursement and reduced risks of audits. Summary tables here. We have table here on symptom documentation in GI and renal disorders, table on diagnostic standards for GI and renal conditions, table on management of complex and overlapping cases, table on multidisciplinary care documentation, table on key legal and compliance elements in documentation, and then next we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which detail is most important to document in a patient presenting with persistent abdominal pain? A. The patient's last dental visit. B. The location, intensity, and radiation of the pain. C. The patient's current workplace setting. Or D. The brand of medication suggested by the patient. Definitely the answer is B. As detailed documentation of the pain's location, intensity, and radiation helps narrow the diagnosis, distinguishing between potential conditions such as pancreatitis, appendicitis, or gastroenteritis. Failure to document these critical elements can lead to diagnostic delays and inappropriate treatment. Question 2. What is the primary purpose of documenting GFR and creatinine levels in renal disease management? A. To track patient compliance with medication. B. To determine baseline renal function and stage disease progression. C. To assess the patient's body mass index, BMI. Or D. To calculate the patient's caloric intake recommendations. Definitely the answer is B. To determine the baseline rate of the renal function and the stage of the disease progression. As documenting GFR, glomerular filtration rate, and creatinine levels allow clinicians to or providers to evaluate kidney function, identify the stage of chronic kidney disease CKD, and monitor for worsening or response to treatment. Neglecting these markers can result in inadequate management of renal conditions. Question 3. When documenting a patient with a nephrotic syndrome, which detail is least critical to include? A. The presence of proteinuria and hypoalbuminuria. B. The patient's dietary sodium intake. C. Details of the patient's prior employment history. Or D. The severity of and progression of peripheral edema. Definitely the answer here is C, as employment history is unrelated to the clinical understanding and management of nephrotic syndrome. Key documentation should focus on symptoms like proteinuria, hypoalbuminuria, hypoalbuminemia, and edema, which are critical for diagnosis and guiding therapy. So the choice was the presence of proteinuria and hypoalbuminemia, which is fine, but the least is C. Answer is C for the least critical to include. Question 4. Which symptom is most relevant to document in a patient suspected of having GI bleeding? A. Daily caffeine intake levels. B. Changes in stool color, consistency, and associated symptoms. C. The brand of over-the-counter supplements taken. Or D. The patient's preferred exercise routine. The answer is B. Changes in stool color, consistency, and associated symptoms. As stool color and characteristics, example, black, tarry stools indicating upper GI bleeding. Provide clues to the source of bleeding and inform required diagnostic evaluations such as endoscopy. Other factors like exercise routines are minimally relevant in this context. Question 5. Why is multidisciplinary documentation essential in GI and renal disease cases? A. It reduces the need for follow-up check-ins with certain specialists. B. It enhances team collaboration and ensures a unified treatment approach. C. It limits medical notes to single specialty input. Or D. It shifts accountability only to the post-procedure care team. Definitely the answer is B, enhancement of the team collaboration, as multidisciplinary documentation ensures that all specialists involved in the patient's care, such as nephrologists, dietitians, and gastroenterologists, are aligned on treatment goals and strategies. This approach promotes continuity of care and minimizes risks of conflicting directives or missed interventions. And here we come to end of this lecture. Thank you very much and goodbye.